A very good afternoon to everybody present here. Thank you for coming. I'm Dr. Akshay Kumar, Additional Professor, Department of Emergency Medicine. And today we're going to present an interesting case that presented to us in this month only, in the year of 2025. I hope it will be interesting and will be exciting to learn from this case. So it will be presented by Dr. Sana, one of our junior residents, and then the discussion will be led by Dr. Vaishnavi. So, Sana, you can start.
Good afternoon, respected dignitaries. So, we are going to discuss one of the very interesting cases that we have managed in the recent times. And we, the Department of Emergency Medicine, would like to call it as the Cold Conundrum, Race Against Time. And I am Dr. Sana Twinkle, junior resident in the Department of Emergency Medicine. So, we received a 35-year-old male of unknown identity who was brought to our trauma center on 16th January 2025 at 10:20 a.m. He was initially assessed by the triage nurse, and the pre-hospital information he got was the mechanism of injury was unknown, and it was somewhere around 7:30 a.m. Initial injuries that were suspected were head injury and musculoskeletal injuries. Symptoms were not known because the patient was not accompanied by anyone. He initially received some amount of treatment from Civil Hospital Ballabgarh and was referred to the higher center. And this was around 10:20 a.m. So, in view of decreased responsiveness, he was triaged as red, and code red was announced, and the patient was shifted to red area. Again, this was at 10:20 a.m. where all these things were done. So, we have started with our primary survey. We stabilized the C-spine with manual inline stabilization and with the hard cervical collar, and all the monitors were attached. On assessing the airway, we did not find there was any stridor or any secretions that were present in the airway. However, the patient's GCS was E1, V2, M2. So, he was intubated with an ET tube of 8 mm, which was fixed at 22 centimeters. We have done an RSI, and etomidate and succinylcholine were used in this process. So, on assessing the breathing of the patient, his respiratory rate was 16 per minute. Chest compression test was negative. Saturation of this patient was not recordable, and bilateral air entry was present and equal. So, post-intubation, these were the initial ventilator settings that we have put for the patient. Then coming to the circulation, the heart rate of the patient was 45 beats per minute. His blood pressure was 106 by 68 mmHg, and pelvic compression test was negative. There was no active bleeding that was present in the patient. And this was the VBG that we had sent while after securing the IV cannula. We can see that there is a metabolic acidosis which is present with a base excess of 5 and a lactates of 4.3. We went on to do EFAST for the patient. Looking at the subxiphoid view, as you can see that there is no anechoic shadow around the heart, suggesting that there is no pericardial effusion. Looking at the hepatorenal pouch, there is anechoic shadow which is present between the liver and the kidney, suggesting that it is positive on the right side. Then on the left side, once again there is anechoic shadow which is present between the spleen and the kidney. It is positive on the left side. Looking at the pelvic region, you can see this anechoic shadow which is surrounding the bladder. Again, it is positive in the pelvis. And the bilateral thoracic scan was also done for pneumoscan, and sliding was present, as you can see the seashore appearance here. Coming to the disability part, GCS was E1, V2, M2 of the patient. Anosogorrhea was present, right more than left, and they were not reacting to light. And the RBS of the patient was 299. On exposing the patient, we found that the patient was extremely cold to touch. Now, we all know that we are living in Delhi and it's extremely cold here. We are living in such cold winters. Like the minimum temperature reaches almost to 4 degrees Celsius. However, all the patients that we receive in trauma are usually cold at this point. But this patient was, entire body was cold. Even the trunk was also cold for the patient. And the patient was having bradycardia of 45. And you can see here on the monitor, we can see there is some amount of J point elevation that we can see over here. This made us think to do further that what we wanted to do was check for a core temperature of the patient, and we went on to do a rectal temperature for the patient. We inserted a rectal probe and the temperature came out to be 26.2 degrees Celsius. So the normal temperature is somewhere above 35 degrees Celsius. This is something that is very, very, very low, and that too in a trauma patient, that is 26.2 degrees Celsius. So, and at the same time the ECG was also done, which showed, which is this. As you can see, the heart rate is 35 beats per minute, it is sinus rhythm. there is diffuse J point elevation that is present over here and diffuse ST depressions. So these are nothing but the Osborn waves which are present in this patient, which is very typical for hypothermia, though not very specific, still it is present in hypothermia. And as you can see, the Osborn waves, the height of the J point is very high. Usually the height of this J point correlates with the degree of hypothermia that the patient is having. So the first conundrum that we faced here was, our patient was having severe hypothermia and he was suspected of a traumatic brain injury because there was anisocoria and the patient's GCS was on the lower side. FAST was also positive for the patient. Now we wanted to know what to treat first. Should we treat the hypothermia or should we shift the patient for CT, and maybe the patient might require a surgical intervention. We didn't know at this point. So what we did in our trauma center was, first we thought of warming the patient actively. So we started active external and internal rewarming for the patient by using the warming blankets and the bear hugger which is present in the trauma center, along with IV fluids which are warmed to 42 degrees Celsius. This is the fluid warmer that is also present in the trauma center. So we have warmed the fluids to 42 degrees Celsius and we have given it to the patient. At the same time, we also thought of putting a NG tube and started gastric lavage for the patient. We've used 200 ml of warm saline. For 1 to 2 minutes, we've infused it. And after 2 minutes or 3 minutes, we have aspirated the fluid. So this process we have done for the patient. At the same time, we also put 3 ways of Foley's for the patient and started bladder lavage. So the IV warm fluids, bladder lavage and the gastric lavage was continuously being done for the patient. And the time around, at this point was around 11:30. So now comes our second conundrum. That is, our patient is having EFAS, which is positive. His lactates were somewhere around 5 with metabolic acidosis, and there is a base excess of -5. So what we are thinking is our patient in shock? That's what we're worried about. So actually we're giving fluids for the patient. So as per ATLS guidance, we usually give 1 liter of fluids, and post that if you're suspecting of shock, we have to activate a MHP and we have to transfuse the blood for the patient. And moreover, the patient was EFAS positive. But in our patient, the blood pressure that was documented was SPP more than 98 and the ABC score was less than 1. So at this point, we thought that the lactates which were high and the metabolic acidosis which is there in the patient is because of hypothermia rather than the bleeding that is happening in the patient. So what we went on to do was, we have given fluids to the patient. We have followed false protocol. We've given fluids as per the false protocol, looking at the IVC, collapsibility and distensibility. And also we have continued to do repeated EFAS scans in between so that to make sure that there is no active bleeding going on. The active warming was fast, and it is the intense, like resource intense process, like almost so many JRs and so many nurses and all the HS and all, they were helping and they were actively warming the patient doing this lavages. However, the temperature only increased to 1.3 degrees. So 2 hours have passed and only 1.3. So at this point, from 27.5, just 1.3. So at this point, we've started thinking why the temperature is not improving. Are we doing it right, or should we do something else that we are not doing? So what we did was, we thought we'll continue the warming process, but also we have planned to add something else for the warming methods. So like there is an option of thoracic lavage for the patient, and also there is one more option of providing warm air through the ventilator. But we were worried that if we put an ICD for the patient, hypothermia causes the myocardium to be irritable. What if we do thoracic lavage and that will irritate the myocardium and the patient can go into arrest? So this was a concern that we were having at this point. So after a discussion with all the people that were present on the floor, we plan to go on to change the ventilator, provide hot air to the patient first, and then look at the further course of action. So at this point, we changed the ventilator to provide warm air, and our patient went into arrest. The monitor showed asystole, cardiac pulse was not present, and at 12:40, the patient went into arrest. So immediately code blue was announced. High quality CPR was started for the patient. And after 2 minutes, that is at 12:42, the monitor showed ventricular fibrillation. So we have shocked the patient with 200 joules. And again, CPR was continued. And after 2 minutes of CPR, ROSC was achieved for the patient. These were the post-ROSC vitals for the patient, that is heart rate of 121 with the BP of 116/98. And total 4 minutes of CPR was given, 1 shock was delivered. At 12:44, the ROSC was achieved. So the fifth conundrum is, now we already know that the heart is already irritable, but the temperature is still low. So we wanted to do something else for the patient. Then we thought we'll take risk and we'll go on to do a thoracic lavage for the patient. But since heart is more towards the left side, we thought we'll only do right-sided thoracic lavage for the patient. We went on to put a right-sided ICD and started thoracic lavage for this patient. So at this point, we were actively externally warming the patient, providing IV warm fluids. We were doing gastric lavage, bladder lavage, and also we have started the thoracic lavage, and the time was 12:55. So, and we also at the same time we moved on to do primary survey for adjuncts to primary survey for the patient. Chest X-ray and the pelvic X-ray did not show any life-threatening emergencies that would require immediate management. And at this point, before moving on to secondary survey, we have reassessed the patient. The airway was intubated and the circulation was fine in this patient. The GCS was even VT-M1. There was anosogorrhea still present, and the core temperature at this point was 29 degrees Celsius, and the active rewarming process was still going on. Then secondary survey, the ample history was not available for us because the patient was unattended. On HT2 examination, as you can see, there is a bruise which is present over the right upper lid with sparing of the tarsal plate. There is a sutured wound which is present over the right parieto-occipital area. And there is a lacerated wound which is present in the right popliteal fossa, which is about 8 into 5 into 2 centimeters. And there is no active bleeding. So all of these findings, once again, they're making us think of some kind of traumatic brain injury the patient could be having. So we went on to do an optic nerve sheath diameter as an adjunct to a secondary survey that we usually do in our patients if we suspect a brain injury. So the optic nerve sheath diameter actually tells us if there is raised ICP in the patient. For this patient, by using a linear probe, you go on to do this optic nerve sheath diameter. You can see the globe here, 3 mm from the center. If you measure the sheath diameter, if it is more than 0.5 centimeters, it is said to be significant and suggests of raised ICP. In our patient, on the right side, it is about 0.7 centimeters. Once again, all of these findings, they suggest that the patient could be having a traumatic brain injury and there is a raised ICP. Now, the active rewarming process going on, the temperature is 130. At time is 1:30 p.m. and at this point, the temperature has come to around 30 degrees, and as you can see, the osmolar waves that are present in the patient come down. So now coming to the last conundrum that we were having was, we have the suspicion of traumatic brain injury for this patient. There was a scalp laceration, there was anisocoria, there was ONSD, which is more than 5 mm, and the patient also had cardiac arrest. In such hypothermic patients, if the moving the patient is actually detrimental for the patient because the heart is already very irritable, and if we move the patient can go into arrest. So when to shift for the CT was the biggest conundrum that we had faced, because we know that the patient could be having a brain injury. If not hypothermia, the CT, if there was a significant bleed in the brain, that could kill the patient. There was also EFAST positive, even that can kill the patient. So what we tried to do was, we tried to warm the patient as soon as possible, and then we have shifted the patient for CT. So the patient was warmed till 32 degrees and was shifted for CT, and these were the CT findings that were present in the patient. The patient had a right frontotemporoparietal STH with intraventricular hemorrhage, and there was about 10 mm midline shift. And the CT chest and abdomen was also done for the patient, and it showed 6.2 centimeters laceration in second and third segment of the liver, suggesting of grade 3 liver injury. So we have involved the neurosurgery and trauma surgery teams into this regarding this patient, and trauma surgery planned for a conservative management for the patient. So and since the patient was having indication for operative intervention, the neurosurgery team immediately had taken the patient for the surgery, and the patient was operated. He went right frontotemporoparietal decompressive craniectomy with lax uroplasty. And on day 3 after admission, the patient's GCS was E1, VT, and M3. So this was the case that we had managed. So the further discussion will be done by Dr. Vaishnavi ma'am, who is a senior resident from the Department of Emergency Medicine.
Very good afternoon, respected faculty. So without further ado, let's dwell into the world of hypothermia and polytrauma patients. Hypothermia by definition is defined as a core body temperature of less than 35 degrees Celsius or 95 degrees Fahrenheit, whereas cold stress is defined as a temperature between 35 to 36 degrees Celsius. So hypothermia is more ominous when it occurs in tandem with trauma, and we'll see why and how it occurs. So epidemiology-wise, a study reported 38% of hypothermia cases as primary and 34% as secondary. Predominantly in the men aged 30 to 49, with men affected 10 times more than women because most common cause of secondary hypothermia being drug and toxins. Incidence of hypothermia in trauma patients is reported variedly between 5 to 14% in various geographic regions. And it is said that with increase in the injury severity score, the incidence of hypothermia in trauma patients is drastically increased, with severe injury severity score being reported as 66% incidence of hypothermia. So, hypothermia in trauma also has a varied mortality rate between 25 to 40%. And when the core temperature is below 32 degrees Celsius, there is a mortality rate which almost approaches 100%. There has been a study which correlates the mortality with that of the degree of temperature elevation, as you can see. So, the studies of hypothermia as such and hypothermia in trauma patients has been reported in India. And recently there has been a surge of hypothermia patients, and this was a recent report wherein a 23-year-old female who has developed hypothermia post her death in holy waters of Kumbh. So, looking at the pathophysiology of the traumatic shock, there is endothelial injury which leads to the release of thrombomodulin, which activates the protein C, which further leads to inhibition of plasminogen activator inhibitor that leads to increase in fibrinolysis in this patient. So the primary pathology in traumatic shock, which is hyperfibrinolysis in such patients, leads to a lethal diamond of death. So which consists of acidosis, hypothermia, hypocalcemia, and coagulopathy. So which further worsens the traumatic shock. So there is a vicious worsening of hypothermia and trauma which occurs in tandem. So first looking into worsening coagulopathy, so there was a hypothermia leads to inhibition of coagulation cascade and also decreases the platelet function, which further increases the hemorrhagic shock. So while resuscitating in our patient, even though the patient has initially presented with just grade 2 hemorrhagic shock, we were very cautious about hypothermia worsening the traumatic shock and further leading to the hemodynamic collapse, followed by worsening of acidosis because in hypothermia there is decrease in the metabolism, there is a slowed metabolism and switching over to the anaerobic metabolism leading to increase in lactic acid. So that as we have already seen in our case, the patient had presented with metabolic acidosis with a pH of 7.2 and a lactate of 4.3. So there could be a further worsening of lactic acidosis as well. So it also leads to cardiovascular dysfunction in the form of decrease in myocardial contractility and worsening of arrhythmias. As we have seen in our patient had gone into cardiovascular collapse and leading to one episode of ventricular fibrillation as well. So also there is a decrease in the respiratory drive of the patient, as initially the patient has presented with hypoventilation and coma. There is a neurological dysfunction. So always in patients with hypothermia, there is a decreased sensorium, which can mimic traumatic brain injury as well. Also, in such patients, there is a impairment in the renal function leading to cold diuresis, which causes hypovolemia and further decrease in the intravascular volume, which could further exacerbate the trauma hemorrhagic shock because there is also an increase in the peripheral vasoconstriction leading to tissue ischemia as well. There are various metabolic alterations which occur in patients with hypothermia in trauma as well. There could be rebound hyperkalemia, rebound hypoglycemia, which we'll be discussing in a while. So classification of hypothermia has been primarily into a therapeutic hypothermia, where we are inducing iatrogenic hypothermia in patients such as cardiopulmonary bypass or in patients post cardiac arrest. Or it could be a accidental hypothermia, such as in our case, which can further be divided into a primary hypothermia or secondary hypothermia. Primary hypothermia, which occurs because of the exposure to the extremely cold temperatures, or secondary hypothermia, which occurs because of the presence of intercurrent illnesses, like that it occurred in our patient. So secondary hypothermia could be resulted because of the impaired thermoregulation, such as in patients with stroke, traumatic brain injury, such as in our patient who had severe TBI, or in patients with Parkinson's disease, intracranial neoplasms, or hypothalamic dysfunction, or because of the decreased heat production, such as endocrine failure, or because of insufficient fuel, or because of the neuromuscular compromise. It also could be because of the increased heat loss, such as in our patient, where the patient had presented with polytrauma. Other causes of increased heat loss, such as burns, medications, toxins, and cardiopulmonary disease, can also lead to secondary hypothermia. So this is a European Resuscitation Council staging of accidental hypothermia, where the hypothermia has been divided into various degrees of various stages according to the degree of temperature drop. So if the core body temperature is not there to measure hypothermia, what ERC 2021 recommends is that when the patient feels extremely cold to touch, when the trunk feels extremely cold to touch, in such patient you should always have a suspicion of hypothermia, where the degree of hypothermia or the staging of hypothermia can be based on 4 important parameters such as alertness, shivering, abnormal movements, and consciousness. So as you can see, in patients with mild hypothermia, the first and the foremost sign is abnormality in the movements. The patient will go into lethargy or fatigueness, followed by decrease in the shivering. There is impairment of shivering in moderate hypothermia and decrease in alertness. And finally, the patient will go into unconsciousness with absence of shivering and absence of any movement, such as in severe hypothermia. So measurement of core temperature should ideally be done with the esophageal probe, which is to be placed in the lower third of the esophagus. So we have this esophageal probe in our emergency. And also if it is not available, we can use a bladder probe and a rectal probe as well. So in our patient, previously we had used rectal probe, but the caveat is that the limitation of esophageal probe and rectal probe is that if you are doing a gastric lavage or a bladder lavage concurrently in such patients, that can also lead to a false reading in such patients. So this is a clinical staging again, showing various systemic manifestations according to the degree of hypothermia. What I wanted to highlight in this is that in patients with severe hypothermia, such as our patient who has presented with a core body temperature of 26.2 degrees Celsius, it can mimic brain death. It is very, very important that such patients should not be labeled as brain dead as soon as you have seen the patient. Patient can have fixed dilated pupils, patient can have coma, patient can have areflexia. That is, the brainstem reflexes can be absent in such patient, absent cuff reflex, absent corneal reflexes. So even when such a patient presents to you with a core body temperature which is 26 degrees Celsius, you should not suspect that the patient might be brain dead. Rather, rewarm the patient and reassess the patient. That is what I wanted to highlight in this. Also, proceeding towards the investigation, the first and foremost is the fingerstick glucose. As you all know, that in patients with altered mental status, that is the first thing that is to be done. And also in patients with hypothermia, there is a very high risk of hypoglycemia when you rewarm the patient. Also, other basic labs such as CBC, electrolytes, and lactate. One and most important part of investigation is the coagulation profile of the patient. So it is said that in patients with hypothermia, the patient might be bleeding despite the usual traditional coagulation parameters being normal. Like the PT-INR of the patient could be normal, but despite that, the patient would be bleeding. So in such a case, a thromboelastography will give you an ultimate illustration of the entire coagulation, right from the formation of the clot to the breakdown of the clot, everything. So hyperfibrinolysis is the primary pathology which is worsening in hypothermia and also in patients with traumatic shock, leading to a deadly triad of deadly lethal diet. Also cortisol, TSH, and CT4, because adrenal insufficiency and mixed edema coma can also present in the similar presentation. Creatine kinase, because there is a risk of rhabdomyolysis in such patients. Blood cultures, because whenever there is hypothermia, you should always look into the cause of secondary hypothermia. Unless until you have corrected the secondary causes of hypothermia, the patient may land up with rebound hypothermia. So identifying and correcting the root cause is what is important. Additionally, any toxicology workup if you are suspecting any toxin. The first conundrum that we faced was patient had severe hypothermia with suspected TBI and blunt abdominal trauma with EFAS positive. Whether to manage the severe hypothermia component or whether to shift the patient urgently to OT or versus CT was our first conundrum. So we know that the risk of arrhythmias and the risk of mortality that we have discussed in patients with severe hypothermia, less than 32 degrees Celsius, is almost approaching 100%. So the risk of dying of a patient with arrhythmias is going to be within seconds. The patient might be survived once the arrhythmias and the rewarming has been done. So we initially started with immediate rewarming, giving a warm humidified oxygen. We immediately connected such patient with direct defibrillator because the patient has a very high risk of arrhythmia even with the slightest of movements. It is said that even while inserting an RT or even while inserting an ET tube, the patient may go into arrhythmias, such as the cardiac arrest that occurred in our patient. So peripheral IV and IO access should be obtained. And will you treat ECG abnormalities in such patient? Our patient had a bradyarrhythmia with an initial heart rate presentation of around 36. So always treat the patient, not the ECG. So bradyarrhythmias or tachyarrhythmias can occur in patients who are severely hypothermic, and you should not be treating the bradycardias with any drug. So giving atropine or giving amiodarone or giving any drugs is going to be futile. Just by rewarming the patient and just by intravascular volume repletion, you can correct arrhythmias. So rewarming techniques, as we will be briefly discussing, are passive external rewarming, such as what we did in our patient, removing the wet clothing, blankets, increasing the room temperature. Active external rewarming, such as using the warm blankets, heating pads, radiant heat, or warm baths. Active internal rewarming, such as that we have seen, various lavages and the endovascular rewarming. And ultimate Cadillac of severe hypothermia resuscitation is going to be the ECMO. So active external rewarming can be done with warm blankets or the bear hugger that we have done in our patient. So the second conundrum was whether to give fluid or blood. Since the patient had a shock index less than 1 and the IVC was collapsible with ABC score of 1, we just went ahead and did a warmed IV fluid resuscitation with fluids which were warmed to 42 degrees Celsius and given in boluses according to the false protocol. So it is said that when the difference in temperature of the warm crystalloid versus the hypothermic patient, since the temperature difference is only going to be 10 degrees, the degree of improvement in a patient of hypothermia while receiving a warm crystalloid might not be same as degree of improvement that hypothermic patient might be having with resuscitation with chilled crystalloid. So just by intravascular warm fluids, it is not going to improve the temperature. That is what I wanted to highlight. And despite gastric lavage, bladder lavage, and intravascular volume inflation, patients still did not have a significant improvement in temperature. As we have seen, our patient only had a 1.3 degrees Celsius increase in temperature. So at this point of time, the last conundrum that we wanted to highlight was whether to go ahead and do a thoracic lavage or not. There has been various case reports and review of literature which said that even just doing a thoracic lavage, even while inserting an ICD, the patient can land up with ventricular fibrillation. And the left-sided ICD has a higher risk than that of the right-sided ICD. So despite of all of that, since all the measures have failed, and since ECMO has been the Cadillac or the cardiopulmonary bypass has been the Cadillac, so we went ahead and did a thoracic lavage because the rewarming rate of a thoracic lavage is as comparable as that of cardiopulmonary bypass. So it can achieve a high rewarming rate like that of cardiopulmonary bypass, which is according to 3 to 6 degrees Celsius per hour. So these are the method of test tube placement. Another metabolic abnormality that I would like to highlight is rebound hyperkalemia, rebound hypoglycemia, which should be kept in mind. So as we have answered, shifting the patient to the CT, we have done after the patient has been rebound. Yes, sir. Just conclude. Yes. Yes, I am concluding. Just the last slide. So I would like to first just highlight the hypothermic cardiac arrest guidelines. So a maximum of 3 defibrillations should be attempted until the core body temperature is 30, and after that further defibrillation attempts should only begin after the core body temperature is more than 30. And adrenaline should be withheld when a core body temperature is less than 30 because the metabolism of the drugs is slowed. And after the temperature has been rewarmed with more than 30, the adrenal intervals has to be doubled. I request Dr. Akshay to please summarize. Thank you so much.
Thank you, Vaishnavi. Yes. So we still have 1 minute.
We have 1 minute.
1 minute है sir. 1 minute enough. 258 sir. अच्छा.
No.
Okay.
Okay. There's no point in going on,
Right,
going on.
Sir, so basically this, the case, we were lucky, sir. What happened on Saturday, 11th of January, we had a presentation in the academic section in our department on hypothermia, which really helped management of this patient. So a lot of the theory a lot of what we did was fresh in our minds while we were managing this patient on the floor. So the case highlights the complexity of managing hypothermia in a patient with severe trauma. And conundrums like when to shift for CT, when to shift for OT, when to, how much, at which rate we should give the rewarm fluid have remained unanswered, and there are still just case reports and case series in that direction. The one point I'd like to really highlight is that the assessment of hypothermia and the assessment of core temperature, which is a part of primary survey as part of E exposure, is often overlooked. And in this case, that was the most important thing, is assessing the core temperature of the patient using the rectal probe, because most of the time we just do an axillary temperature or tongue temperature, which is where we picked up the hypothermia. So thank you very much. I don't know if there's time for any discussion, but if there are any burning questions, we are happy to. Okay, thank you.